Okay, so now let's go through the third EKG, and let's start with rate. And it's going pretty fast with 29 across the bottom, and so 29 times 6 is 174. Then let's look at rhythm. Is there a P for a QRS and a QRS for a P? And it's really hard actually to see any P's. I don't see very many P's anywhere in here. I don't think those are P's. I think that's just kind of a wavy baseline. And the reason I don't think it's a P is because a rate of 174 is pretty darn fast, and that usually tends to be an AV nodal reentrant tachycardia, or what we used to call PSVT, or paroxysmal supraventricular tachycardia, which tends to start here in the AV nodes, going around and around and around and shooting the signals down through. And so I call it SVT, but it's really probably better called AV nodal reentrant tachycardia, because technically AFib is a supraventricular tachycardia. So that's what I think is going on here, because it is going very fast. Let's look at the axis. F is positive and 1 is positive, so we're in this normal quadrant here. Then let's next do our intervals, and there is no PR that we can really see. Our QRS looks pretty good. I think it's about 3 boxes again, so we'll say 120. And if we do our bisection method here for the QTC, I think we're okay here too. So then next, let's look at our ST segments and our T waves, and again we'll do them in our order. So let's look at our lateral leads first. I'm going to circle those. And then our inferior leads we can look at too. And finally, the anteroseptal type leads. So let's zoom in here, and we say, okay, you know what, the ST segments look pretty good. The T waves are up, and in L, about the same thing. Let's go to these lateral leads over here, and ST segments look good. T waves are all up over here, so laterally we're fine. Let's go to the inferior leads. T waves are up, ST segments good, good. Kind of hard to say, it's such a wavy baseline, but I think that looks good there. And then finally, let's look at our anteroseptal ones, and we say, ST segments look fine. The T waves are all facing up, so I think we're good with those as well. So what we have here again is a supraventricular tachycardia, and this time we're going to call it an AV nodal reentrant tachycardia. And if you'll remember from the first video, the way that we're going to treat that is by slowing down this node, because again, this is probably where the signal is coming from, either half through here or all the way through here. And so these are the drugs we have available. Adenosine, which is short, quick acting, usually doesn't last too long. Beta blockers, calcium channel blockers. Digoxin is more of a long-acting drug that we don't use acutely. We usually go to one of these 3 as well. So for this EKG, we're going to call it SVT, or an AV nodal reentrant tachycardia, and we're going to say that treatment would be one of those drugs, whether you want to use let's say diltiazem, 20 milligrams. We'll try that and see what happens. Okay, let's go to the next one.